Welcome everyone to another session of The Doc is In, the Cleveland Clinic Abu Dhabi podcast. I'm Dr. Florian Roser, Institute Chair of the Neurological Institute and Department of Neurosurgery. Today's topic is about brain tumors, a very sensitive topic as it affects the patient in a completely different way than any other tumor within the body. My guest and partner today is Dr. Somar Chehab. Dr. Somar joined our team about 5 years ago. He's a very experienced brain and spine surgeon who received his neurosurgical training in some very prestigious neurosurgical university centers in Germany. Welcome, Dr. Somar. How are you today?
Thank you very much. Thank you.
So let me start with a very general view on brain tumors. So being diagnosed with a tumor in the brain or the skull is a life-changing event. Whether this is a harmless, benign tumor or an aggressive malignant tumor. It is very much associated with the fear of losing yourself, your personality, your memories, and other cognitive functions. Understandably, too many wrong perceptions exist about brain tumors. And indeed, if we look into the history of diagnosing and treating brain tumors, only a few decades ago, the life expectancy was dismal. Only few therapies could be offered, and most of them associated with significant impact of quality of life. So obviously over time we're doing much better, Somar. So why don't you give me an update of how we treat brain tumors today?
So indeed, you're right. If we go back around 100 years back, like at the end of the 19th century, the first attempts of brain surgery were started. And despite all the attempts, at that time, the results were still not as expected. Over the last, I would say, 30 to 40 years, this became more systemic in terms of there is a concept how to treat brain tumors, starting with a biopsy, which means just a tissue diagnosis, and getting more courageous in resecting the tumor, and then additional treatments were also offered, including radiation and chemotherapy. Nowadays, this become a concept, and it's a multimodal and multidisciplinary treatment plan, and it's in most of the cases even individualized or down to each and every patient. And the results are way better and promising.
So tell me, so how did we achieve this? Is this just we getting better in surgery, or is it more on the medical oncology side? So how did the survival of patients improve and the quality of life?
In many ways, all of them actually, but still, surgery is still I would say, most important part, or let's say the cornerstone of treatment. All the data that we have still emphasize or re-emphasize that as the more tumor we can get out, the more radical we can be, the better the results at the end of the day. Of course, radiation chemotherapy is a very important part of it, but still the first attempt, resection, is still the most important part.
So why is it so difficult to receive a complete or radical resection? I mean, with any other cancer in the body, the surgeons are really sometimes aggressive, as we know, just in terms of curing the patient from the disease and then giving additional treatment. Why is it so different with dealing with brain tumors?
Brain tumors are, the brain is a little bit different. The concept is, the philosophy of brain surgery is a little bit different. I mean, for an example, if you have, let's say, a kidney tumor, you can, worst case scenario, you can, resect one kidney, you still have another one. If you have a gut tumor, like a belly tumor, you can be very generous taking part of the gut, even 5 centimeters of each side, right? Until you are 100% sure, okay, I have clean borders, right? This can't be applied to the brain. Every millimeter counts. Every millimeter has kind of function. So when we plan a brain surgery, we have to think about, how radical can we be, how aggressive can we be, and at the same time, we have to consider and respect the function of the brain. We cannot be it's not, how to say it, it's not, you cannot just, resect the tumor and knowing that you may end up having a patient with a paralysis, which means a weakness, or even worsening of his clinical condition. So all this needs to be considered. And then with all this consideration, you have to be as precise and as aggressive as you can be.
So despite your surgical experience over the last 2 decades, so what equipment and tools you have available to help you achieve this goal?
So, yeah, that's true. So with time, I mean, it's not just the skills of the surgeons which, makes the difference. We have a lot of tools now we use before the surgery, within the surgery, that can help. Starting with navigation, planning the surgery, mapping, which means that the brain give us a lot of information about the functionality of the brain. Where's the center of speaking? Where's the memory? Where's the movement of the arms, legs movement? All this needs to be considered. Then we use the microscope for precise surgery. Even when you use endoscopes, which is a camera for minimal invasive. And in special cases, for instance, at Cleveland Clinic Abu Dhabi, we also perform surgeries in awake patient to have, minute-to-minute control over the functionality of the brain.
That sounds very scary. Tell me more about the awake surgery.
So awake surgery is a new, it's not a new, but it's relatively new concept that, that the tumor is very close to a very important area, let's say a speaking area. The patient is awake, we start the surgery, the patient is aware of what is going to happen, and then he's gonna get some anesthesia to calm down, and then at part of the surgery where we start operating on the brain, he's awake, and there's someone talking to the patient, showing him, let's say, pictures. He needs to name pictures, even talking to the surgeon sometimes using the hand, using the arm, some cognitive questions and answers while the surgeon's doing the surgery, provoking the brain to a level where, while you're doing the surgery, the patient starts having problem and okay, this is the border, this is where as far as I can get to.
Is this not painful?
No, it is not. The brain has no sensation, no pain sensation. It's just, the skin and the layer beyond the skin, which is painful. But the brain surgery itself the brain itself cannot feel pain.
So tell me about the Fluorescence-guided surgery, which has been recently introduced to the Cleveland Clinic Abu Dhabi.
So this is also a new kind of technique we use intraoperatively. We give the patient a dye, a kind of fluorescence, which we can see under the microscope. It gives us a different color of the tumor cells under the microscope. It somehow differentiate the tumor from the normal brain tissue. It's also an additional tool that we use to have more precise kind of resection borders.
Mm-hmm. And I think I'm glad you're mentioning that, because this is an important concept when we bring everything together, right? So we have the experience of the surgeon, we have great tools in the OR to maintain this balance of what we need to do and what we also need to preserve, because that is really important concept, right? That you try to maintain the quality of life, which is, I think, the most important factor here, and that is addressing the fear and the anxiety of the patients when they're undergoing brain surgery. But at the same time, we have this need to remove as much unhealthy tissue as possible. So having this balance, all these techniques you mentioned in your description are very important for us to achieve this goal, that we can resect much more tissue than we did in the past, at the same time preserving the function of the patient, that he does not lose memory after surgery or has personality changes. And then after surgery, when we have new imaging and see how the situation looks like, we then move forward to an interdisciplinary team. And then tell me how that works at the Cleveland Clinic Abu Dhabi.
So here now with the opening 2 years launching of the Fatima Mubarak Center, we have an interdisciplinary approach to treatment, brain tumor treatment, in terms of the surgery we talked about and radiation, all the possibility of radiation or radiosurgery, and medication in terms of chemotherapy. All these options are there, available on the highest and updated level, and we discuss every single patient in what we call tumor board, which is a meeting we have every second week, including the neurosurgeon, the radiologist, the oncologist, the radiation therapist, if necessary, the psychologist, everyone who can give his input to have an interdisciplinary and individual plan at the same time to fit what the patient benefit the most.
Yeah, and I think this is one of the other differentiations to cancer treatment, that whatever we do with brain tumors, it is very much individualized, right? Because we have guidelines, which we follow, of course, but the situation of every patient, it starts at the location of the tumor within the brain, needs a very, very individual approach in what we're offering that. And so now tell me about how chemotherapy, for example, changed over the last years, and what you expect from this treatment in the future.
So now there are multiple medications, what we call the first-line treatments, second-line and third-line treatments. Those treatments are now individualized depending on the level of on that cell, even molecular biology, cell tissue of every individual patient. There are some markers, we call markers, which means molecular genes within every tumor cells that give us some information how this tumor will respond to this certain type of treatment. And as I said, there is the first line treatment, and then there are a second, and even now there are, with this new evolvement of immune therapy modulation, as third and fourth line treatment, which are still not standardized but very promising.
So I believe when we put everything together, right, that we have to talk to our patients in a way that we rather talk about controlling the tumor over lifetime or as long as possible, and not really about cure, which again is a different concept, that we can't or shouldn't aim and talk about cure because this is rarely possible. So then we have these two spectrums of patients. On the one hand, with a benign encapsulated tumor, which we surgically can treat, and on the postoperative imaging study, we barely don't see any tumor, but we know that there's a risk of recurrence and have to follow up with the patient over a lifetime, even up to 20 years, because a small recurrence in that area can happen. On the other spectrum, we have these patients with very aggressive tumors where we can't do a complete resection because of the reason you mentioned, very close to eloquent areas where the patient would lose function if we go in. Those patients are very difficult to manage because the chemotherapy and the radiation treatment can control these tumors only for a certain period of time until we see recurrence. And then obviously a second surgery sometimes doesn't make sense because this is where we actually stopped at the first surgery. So that is very challenging for us and the patients to bring together, right, this concept. This is a very individualized approach we need to take for everyone. Where do you personally see the future moving forward?
I would just, reverse that, like when the question about, or just, add some one additional point that with all this information that we have now, a lot of new ideas comes in, and their research is very important at this stage. And I would ask you, what do you think about, research at Cleveland Clinic?
Yeah, so I believe we are in a very blessed environment here, right? So first of all, we have all the tools and equipment available to do the clinical part of treatment. And then we live in an environment where we have excellent universities around us, like to mention the Khalifa University or the New York University, Abu Dhabi, who work already together with us on very important projects, right? Within the OR, including AI-driven technology improvements and precision medicine, targeted treatment, so that we are able to participate in international multi-center trials, which we bring into the Fatima bin Mubarak Cancer Center, which all will contribute to a better survival and a better quality of life of our patients. And I really believe this environment will give us the opportunity and the chance over the next years, to be one of the leading centers, not only in the region, but playing on the world stage when it comes to clinical neuroscience research and improvement of outcomes. So thank you, Dr. Somar. I think we covered a lot of important topics today. Thanks to the audience for listening.